Leading
The
the
echo is coming
discussion
back.
on valvular heart disease will be Dr. Philip Peberau, Head of Cardiology Research, Professor of Medicine at University of Laval, Cardiac Research Chair in Valvular Heart Disease, Editor-in-Chief, Journal of Heart Valve Society, and he will be going to give his talk on early intervention in asymptomatic severe aortic stenosis. Dr. Philip Peberau, please.
Thank you so much. I hope that you see well my slides. Okay?
Yes, seen and heard well. No problem.
Thank you so much. It's a great pleasure and privilege to present at this Indian Association of Echo webinar series. And so we're going to discuss early intervention in asymptomatic severe AS. I do have some disclosure that are important to mention. And in aortic valve replacement, timing is everything. The Anglophone people often say timing is everything, but this is indeed the case. If you intervene too early in the course of aortic stenosis, you may expose the patient to the risk of the procedure itself. And the prosthetic valve is associated with many complications: thrombosis, endocarditis, degeneration, stroke, etc. On the other hand, if we intervene too late, we may have irreversible damage to the myocardium. And so even if we do a successful operation, well, the patient may still have some symptoms, sequelae, and heart failure. So if we look in the guidelines, these are here the American guidelines, but European guidelines are similar. For patients with severe AS, so they have high velocity, more than 4 meters per second, and they have no symptoms, there is no class 1 indication for valve replacement, unless there is LVEF less than 50% or an indication for another cardiac surgery, such as a CABG. But there are some, let's say, openings, some class 2A. If you have very severe AS, markedly elevated BNP, or rapid stenosis progression. And so the dilemma in the patient with asymptomatic severe AS, should we do AVR now, like prophylactic, or the watchful waiting, the wait for symptoms or for LV dysfunction to intervene? So I want to discuss this trial that you know very well, published in New England Journal of Medicine last year. This is the early TAVR. This is one of the 4 main trials that's been done in the field. So these were asymptomatic patients with severe AS, and they were randomized to transfemoral TAVR with a SAPIEN 3 valve versus clinical surveillance. And the primary endpoint was a composite of all-cause mortality, stroke, or unplanned cardiovascular hospitalization at 2 years, okay? And, well, you know the results, but there was a superiority, a major superiority of early TAVR versus clinical surveillance at 2 years. But the endpoint, as you will see, was mainly driven by rehospitalization. No difference in mortality with early intervention. No difference in stroke. There was a numerical trend, however, you see, patients who were under clinical surveillance had somewhat higher rates of stroke. But again, the endpoint was driven mainly by unplanned cardiovascular hospitalization. And most of the hospitalization you see occurred in the first 6 months, because if the patient was hospitalized for a crossover to TAVR in the clinical surveillance arm, it was considered as an endpoint. So we've been criticized for that. And so we also presented this, I think, important composite endpoint, which is, again, death, stroke, but here it's only hospitalization for heart failure. And still, you see, there was superiority of early TAVR versus clinical surveillance here. So, and there are also some pre-specified secondary endpoint that goes in the same direction. And some of these endpoints are very important, such as the favorable health status outcome, which was defined as a KCCQ score. So it's a metric of quality of life, as you know, more than 75, that did not decrease more than 10 points from baseline. So you see there was a much higher proportion of patients with favorable health status outcome at 2 years in TAVR versus clinical surveillance. Also, given we are at an ECHO meeting today, you see that this secondary endpoint of integrated, what we define as integrated LV-LA health, which was defined as meeting all the following ECHO criteria. So you needed to have a global longitudinal strain more than 15%, no hypertrophy, so LV mass index less than 115 for men, 95 for women, and no dilation of the left atrium, so left atrium volume index less than 34. So if you have these three criteria, you are considered to have LV-LA health, and you see that the proportion of the patient was again significantly higher in the patients who underwent early TAVR versus clinical surveillance. Now, this is the early TAVR, this first trial, but there are 3 other randomized trials. There's been the EVOLVED, that actually EVOLVE-DS did not meet the primary endpoint. There was no difference in mortality. And there is AVATAR that met the primary endpoint, superiority for lower rate of mortality with SAVR, so surgery. And there was a recovery published in New England that was the first to be published that met the primary endpoint for superiority rate of mortality with SAVR again. So we may try to understand why, for example, the only trial that is negative among the 4 is EVOLVE. And you can understand why, because you see the patients who were randomized to early AVR, because in EVOLVE, 80% of the patient was surgery, 20% of TAVR. You see that the time from randomization to finally getting the valve replacement was about 5 months. So it was not really early AVR, and this is very different in early TAVR. In the early TAVR arm, if you were randomized to early TAVR, you got your TAVR within 14 days in median. So that might be the reason why the EVOLVE was negative, one of the reasons. So we did, with Philippe Généreux, we did a meta-analysis of these 4 trials and found that there was a superiority again of early AVR, SAVR or TAVR, in terms of heart failure hospitalization, major superiority, unplanned cardiovascular hospitalization, and also, interestingly, stroke. Again, there is a benefit in terms of stroke, which is a very strong endpoint, of course, of intervening earlier. However, there was no difference in mortality, all-cause, or cardiovascular mortality, maybe some trend, but not to be discussed. So, although according to this meta-analysis, overall results of these RCTs favor early intervention in asymptomatic CVAS, I think we'll still need to continue to individualize and optimize the timing of AVR based on the echo parameter that we are measuring, and especially the parameters of cardiac dysfunction, damage, and failure. And in this regard, you know that one thing we need to look at is the LV ejection fraction. And we know that in asymptomatic patients, if the LVF is lower than 50%, this is a class 1 indication for intervention. The problem with the LVF, as you know, is it lacks sensitivity. It is not sensitive enough to detect the subclinical myocardial dysfunction. And if you look only at LVEF, you may consider that everything is fine, but if you look at other parameters, that might be a different story, right? So we did this study that was several heart valve clinics put together, an international effort, and we found 2 echo risk marker in asymptomatic CVAS. The first one, not surprisingly, peak jet velocity. If you have very severe AS, so peak jet velocity more than 5, very bad outcome. And I think this further reinforced the recommendation that is already in the guidelines that if you have very severe AS, this is a class 2A indication for intervention. The second one was LVF, not surprisingly. But in this study, all patients had the LVF more than 50% at baseline, because otherwise they would have had an indication for intervention. But what we found is that the patient with LVEF between actually 60 and 50, so the blue line, actually had worse outcomes. So this means that, maybe this cut point that we have of 50% in the guidelines is too low, is not sensitive enough, and maybe we should consider a higher cut point. And this is actually what was implemented in the last edition of the guidelines. The American guidelines say, well, if you have LVF declining now below 60, not 50, this is a class 2B. And the European guidelines kind of use a different approach. They say, well, if the LVF declines below 55, this is a class 2A. And I think, both are working well, but I like the 55 2A. So the other way to overcome the lack of sensitivity of LVF is to look at global longitudinal strain that we can easily and automatically measure now with our Doppler ecosystem. And indeed, if you have a global longitudinal strain that is less than 15%, well, even if the LVF is preserved, even if it is more than 60%, well, you have 1/3 of the patient who have abnormal longitudinal function, and if they do so, they have worse outcomes. So the other thing that we propose with Philippe Généreux, sorry about that, I'm coming back, is the cardiac damage stage classification. So what we did with this classification is to integrate all the risk markers that we discussed in a classification, and we have 4 stages. Stage 1 means damage at the level of the left ventricle with increased LV mass, grade 2 or more diastolic dysfunction, EF less than 60%, not 50, global longitudinal strain less than 15. If you have one of the criteria, you qualify for stage 1. Stage 2, left atrial mitral valve damage with early dilation, moderate severe MR, AFib. Stage 3, we go upstream, pulmonary arterial tricuspid valve damage. And stage 4, moderate or severe RV dysfunction. So, and what we look at this cardiac damage classification in asymptomatic patients with severe ES, with, again, an international collaboration. And look at this. If you have stage 1, 0 or 1, this is blue or yellow, you're good. You're going to have an outcome that is quite good, up to 1 year and even 2 years. But if you have stage 2 or more, then you have an impact on mortality within the next year. So I think this is a strong argument to consider early AVR in this patient with asymptomatic CVIS if they have stage 2 or more. Stage 0, 1, you can continue on clinical surveillance, but I think stage 2 and even more, of course, stage 3, 4, you should intervene rapidly. It's not yet in the guidelines, but I think it would be ready to be implemented. So I'm going to conclude, and I have 3 slides for the conclusion. I apologize, but I want to really give you a future perspective. So there is not yet any class 1 indication for this patient with asymptomatic CVIS, unless, again, if they have LVF less than 50% or indication for another cardiac surgery. But they are already in the guidelines that we have now, class 2 indication if very severe ES, so peak jet velocity more than 5, fast stenosis progression. So fast stenosis progression is a progression rate of peak velocity of more than 0.3 meters per second per year, markedly elevated BNP, which is 3-fold normal, and LVF less than 55%. So we already have several indications, right? But on the basis of the recent randomized trial, meta-analysis, we expect that the 2025 edition of the guidelines, so the European guidelines, will be published in about 2 weeks, even less than that. I predict, but I don't have any crystal ball, that they will include a class 2A, probably not 1 because there is no difference in mortality, 2A indication for early AVR, SAVR or TAVR, in a priori all patients with asymptomatic severe AS and high gradient. But again, there will still be the need to individualize and optimize the timing of AVR, and based on abnormal LVL, cardiac damage stage, or elevated BNP or troponin. So this is the algorithm that I would like to propose. If you have an echo, any parameter suggesting that the stenosis could be severe, of course, mean gradient more than 40 or peak jet velocity more than 4. But even if you have low gradient, but you have a valve area less than 1 centimeter square, or the Doppler velocity index less than 0.25, I think, or if the stenosis severity is uncertain between moderate and severe, we should do an early referral to a multidisciplinary heart valve team in order to get a more comprehensive, enhanced characterization and categorization, and eventually repeat the TT, perform a dobutamine stress echo or calcium scoring to confirm severity, do the blood biomarkers, and eventually start to prepare the intervention by doing CT angio in particular, by doing dental care. I think everything we can do upstream, dental care in particular, we're going to win sometime. And then, depending on the classification of the patient with AS, if you have symptomatic severe AS, then it's a no-brainer. Class 1 indication for intervention. They should have expedited AVR, ideally within 1 month. If they have asymptomatic, true asymptomatic severe AS, we should do elective AVR. We'll see what the guideline will say, but ideally within 3 months and within, I would say faster, within 1 month if you have some risk markers such as abnormal LV health, cardiac damage stage 2 or more, or markedly elevated BNP. Having said that, I think we should have a shared decision-making with the patient. And of course, there are some of these patients with asymptomatic severe AS in whom we should consider to defer AVR until symptoms occur. In particular, the patients who are very young or very old or have marked frailty, or also the patient with asymptomatic severe AS but with low gradient, because we have not really validated the early AVR in patients with low gradient AS. It's only in high gradient. So this patient, we can continue. It is reasonable to continue clinical and echo surveillance probably every 6 months, as well as, of course, the patient who are confirmed to have non-severe AS. So it's really now what I'm presenting is a paradigm shift in asymptomatic severe AS. So we're going to go from the previous approach, or the current approach, is clinical surveillance or watchful waiting in a priori all asymptomatic patients with severe AS. And so this is the default strategy, and consider early AVR in selected patients with the risk marker that we discussed. So very severe AS, fast stenosis progression, markedly elevated BNP. So we're going to shift from flipping the script from this one to early AVR in a priori all asymptomatic patients with severe AS, and consider to defer AVR until symptoms occur in selected patients with the specific criteria I just mentioned. Thank you so much for your attention.
Thank you, Dr. Fibrow, for the excellent lecture on early intervention in aortic stenosis. You forcefully put your points for early intervention in asymptomatic severe AS, especially with the very severe AS where the velocity is more than 5 meters per second. So apart from grading the severity of the aortic stenosis, you have to grade the stage of the aortic stenosis also. That also you have put forward your arguments for staging the aortic stenosis severity. Great. The other thing is, apart from looking at the left ventricular function by using only the ejection fraction, you have to look at the global longitudinal strain and the left atrium diastolic dysfunction. All the parameters have to be taken into account when you want to consider the patient for early intervention. And there are a number of studies which you have quoted where the early intervention has produced better results than watchful waiting in asymptomatic severe aortic stenosis. If there are any questions from the audience, there is no question from the chat box. If there is any other questions from the other panel, you will be able to glad to answer.
How much importance will be given to isolated GLS in the next guideline which is coming? Any particular level of GLS beside 13? Or will the decision be based mainly on GLS times?
Yeah, so according to the meta-analysis on GLS and the definition we use for LV health in early TAVR, it was based on the meta-analysis done by Julien Ternac and colleagues that identified a cut point of 15%. I have to say that 15% is maybe a bit low for aortic stenosis. So I start to worry a little bit when I am, at 16, 17, that there might be some subclinical dysfunction. But yeah, I think a definitive cut point, when you are less than 15%, this is abnormal.
I have a question. Does doing an MRI and assessing the scar burden, the fibrosis burden, helps in decision making?
Yes, and yes, I think yes and no, because for now I think MRI has been mostly used as a research tool and not very much used in the clinical management of patients with aortic stenosis, right? I think what MRI can do is to assess the extracellular volume, the myocardial fibrosis, the focal and diffuse fibrosis with LGE and T1 mapping. And in the evolved trial, for example, they kind of selected the patients who had elevated troponin and who had evidence of midwall fibrosis at MRI, and they found actually the goal was to try to enrich the cohort in terms of risk. But maybe this was not a good idea because finally, the trial was negative. I think when you have midwall fibrosis, I do not mean it's too late, but it's a marker of probably advanced disease, and ideally you want to intervene before that. And there are some I could not share, but we are doing some analysis now, on cardiac damage staging and LV health in early TAVR. And what we found is a bit the opposite of what they've expected, is that there is more benefit of early AVR in patients who have less advanced damage than the others and less fibrosis, you see, and maybe lower biomarkers, which again, I think provides strong argument for earlier intervention before the damage occurs. Because once the damage is there, once the fibrosis is present, it generally does not regress. That's the thing,
Great. So one more thing. So if you have a coexisting amyloid, how does this classification behave?
That's a very good point. As we know, you may have around 12 to 13% of patients who especially undergo TAVR who have cardiac amyloidosis. And so, for example, the cardiac damage staging I presented or the abnormal global longitudinal strain may actually be related more to the amyloidosis rather than to the aortic stenosis. So I think it does not change much the strategy and the interpretation of the results. But because let's say patient has a severe AS, no symptoms, and has concomitant cardiac amyloidosis and cardiac damage stage 2 or 3. Still, even if the cardiac damage is not related completely or at all to this aortic stenosis and more to the amyloidosis, these patients are more vulnerable to the pressure overload imposed by the AS, and still you would need to maybe intervene earlier rather than later, maybe even more in patients who have concomitant cardiac amyloidosis or diabetes or coronary artery disease, you see. So I think it does not change the clinical implication. However, you want to know if there is cardiac amyloidosis, because then you may still do the AVR, because there are some the initial studies were saying, maybe AVR is futile in patients with concomitant cardiac amyloidosis, but the most recent studies showed actually not. When you have severe AS, whatever is the concomitant disease, you need to intervene because it's a deadly disease. However, if you also have been able to detect there is cardiac amyloidosis, then you may also have implement therapy targeted to the amyloidosis, tafamidis or others. And same, you want to know all the concomitant disease that the patient has to not only do the AVR, but also treat the other risk factors, hypertension, coronary artery disease, diabetes, amyloidosis, etc.
Thank you.
Jason, can we move forward now?
Yes.
Yes.
I will invite the first speaker from Indian Academy of Cardiography, Dr. Samir Srivastava. He is the Chief Non-Invasive Cardiology and Vice Chairman Cardiac Sciences Cardiology and Interventional Cardiology at Max Healthcare, New Delhi. Samir Srivastava, please. Dr. Samir?
Unmute yourself. Yeah.
I'm okay.
Go ahead, Samir.
I share my slides.
Yes.
Please share your slides.
Seen well. Go to presentation mode. Yes.
Yeah. Good to go, sir.
Good to go?
Yes.
Okay. Let me just readjust my panels. So this is a young and a heavy heart, and multimodality is the way forwards. This is what I'm going to highlight in this presentation. This is going to be a short presentation about a very long topic, but all the same, it's going to be useful. So this is what Voltaire said. He said, the art of medicine consists in amusing the patient while nature cures the disease. And my addition is, if at all. So here is the clinical scenario of this 15 years old boy. He was asymptomatic till about 12 years of age. He's studying in 7th standard, which is a little slow for his age. Complains of shortness of breath since almost about 3 years. There was a gradual worsening of shortness of breath, and currently he is symptomatic on routine activity. No significant past medical history. Trust me, I took a very detailed history, no addictions, and he's essentially a vegetarian person. Clinical physical examination, general physical examination. There was nothing much to report back home. And this was his clinical issues. Pulse rate was 90. Blood pressure was 104/70. Saturations were reasonably good. Respiratory rate was 24. His BMI was 19.3, which is kind of okayish. He had a palpable S4. Apex was down and out, so much so for his clinical presentation. Now, these are the interesting things about his investigations. Here is the catch. If you look at the ECG, this ECG has distinctly short PR with very prominent delta. Now I'm going to come back to this ECG in a while, because when we go through the whole presentation, we'll come to a conclusion that this is actually probably not a bypass tract, and it is something else. X-ray, dilated heart, kind of LV types, pulmonary venous congestion, expectedly so with this kind of a heart. Right atrial enlargement is there. These are the blood investigations. Just to highlight the blood investigations, he had transaminases, which was high. His OTPTs were high, so his SGOT was 1084 and SGPT was 397. Other than this, there was nothing significant. Yes, his pro-BNPs was 4504. So he was clearly in filling pressures were being high. His CPKs were 642, and this is in absence of any injury or on statins. CPK-MB was marginally raised, but nothing when it comes to ratio. And his myoglobin was 736 again, which was higher, and LDH was high. These are his echo pictures. Hugely dilated, hugely hypertrophied heart. Very seldom do you see such hugely thickened heart. This is, if you look at these pictures, he has little bit of a pericardial effusion around the RA, but otherwise this is a hugely thickened heart. bit of mitral regurgitation. Again, nothing to talk back home. But if you, a little bit of aortic regurgitation and tricuspid regurgitation too. When you look at the IVC, your IVC is, sorry, this is the M mode across the LV. IVC is collapsing and it is not hugely dilated. So LF, he was on diuretic, so expectedly he could be having thinned out IVC. Global longitudinal strain was distinctly low, and important is that it didn't conform to any specific pattern. It was global. So, I mean, we were trying to look for amyloid, because if you look at the echo texture, this echo texture was very solid-like thing, which was not sparkling in hypertrophic cardiomyopathy. We were thinking in terms of sarcoid, but again, with that kind of an ECG, you don't expect people to have amyloid, because in amyloid, the most classical ECG presentation, though not as sacrosanct feature, but in amyloid, you expect to find low voltage syndromes and PR interval which is prolonged. Here we found that the PR was short and there was a delta, and R waves were fairly well maintained. And this was suggestive of a bypass or a WPW syndrome. We went ahead and did some MRI pictures, and these MRI pictures do show that the LV is not as good. We could see that in echo also, but if you look at this long plane of MRI, you find that the LV is not very brisk. And in short axis also, we find that the LV is not very brisk. LG was very interesting, because if you look at the LGs, there is a sparing of the mid-septal scarring. So LGs, if there is a sparing of mid-septum, it has its own connotations. T1 relaxation time also we did, just to rule out hemosiderosis, nothing great in that. Took some endomyocardial biopsy, which showed vacuolations, and we did some pus staining. Again, it showed that there was vacuolations, glycogens, which was there. Electron microscopy proved the same. And then we were debating what was the most likely diagnosis. So we were looking at PRKAG2 cardiomyopathy, LAMP2 deficiency, alpha galactosidase deficiency, which is our Anderson-Fabry's disease. And we were looking at alpha glucosidase deficiency, which was acid maltase deficiency also, which is in Pompe's. We kind of coned down to PRKAG2 cardiomyopathy and LAMP2 deficiency. And why we came to LAMP2 deficiency is because these are the 2023 ESC guidelines for management of cardiomyopathies, and in which we discovered that this was the kind of algorithm we used to come to our diagnosis, that it was a Danon. So LAMP2 deficiency is Danon syndrome. So if you look at this, we'll go by the third column, which says extreme LVH. Extreme LVH is seen in three conditions in a child: Danon's disease, Pompe's disease, and PRKAG2 cardiomyopathy. Of these, short PR and pre-excitation is seen in Danon's, PRKAG deficiency, Anderson-Fabry's disease. So clearly, we are not looking at Anderson-Fabry's disease because this was not an extreme LVH. So we are limited with two possibilities, glycogenosis and Danon's disease, of which we, and PRKAG2 cardiomyopathy, where we would say that if you have transaminases, it favors Danon's. If you have CPK, which is high, favors Danon's. We got an ophthalmic examination done. This was a fundus, which was tessellated fundus, again pointing out towards Danon's. And neuropsychological evaluation we did, where there was a mental retardation. Now, if you look at his standard, he was studying in 7th standard at the age of 15 years, which is almost about 3 classes or 3 grades or 4 grades down. We should have thought in terms of it earlier, but many a times wisdom comes only delayed. So here is the differential diagnosis from the 4 that we had kind of honed down, in which if you look at the pattern of inheritance, this is clearly an X-linked pattern of inheritance. He had one person who died in the family who was a male and sudden cardiac death. Then there is transaminitis, pre-excitation, LVH on ECG, and myopathy. All of them, they favor diagnosis of Danon's. Now in Danon's, there is a very interesting thing. It is not the bypass tract which causes pre-excitation. It is the vacuoles that they become so large that they kind of start short-circuiting the AV node, and they are actually not the tracts which are there. It is the vacuoles which are electrically active. We did some gene studies, and ultimately we found that it was a LAMP2 variant. So we were pretty much sure. We did involve cardiologists, neuromuscular specialists, pneumologists, and of course, all of us claim that we are advanced heart failure specialists, so we were all there. So where were the clinical red flags? The clinical red flags were short PR, massive LVH, skeletal myopathy in form of increased CPK, intellectual disability, and X-linked inheritance. So these are the 3 best describes Danon's cardiomyopathy. And if you look at this, we had vacuolar degeneration with intracytoplasmic inclusion, which was evidence on the para-amino shift staining. MRI showed diffuse LGE with sparing of the mid-septal region. This is very classical for Danon's. And of course, genetic mutation we found out was LAMP2B gene. Now, the most frustrating and disappointing part of Danon's cardiomyopathy is that it has no specific therapy. We have to, as of now, be entirely dependent on the 4 pillars of intravenous diuretics, RAS inhibitors, beta blockers, MRAs, SGLT2 inhibitors. So we are looking at something which is kind of not specific treatment, and ultimately, whenever the need be, you go ahead with transplantation. Quick review of literature. X-linked progressive vascular cardiomyopathy is Danon's. Early disease is preserved ejection fraction and normal cavity dimensions. With progression, there is a massive LV hypertrophy, usually concentric, may have an associated RV hypertrophy. The biggest hearts, septal thickness as much as 65 millimeters, and the autopsy weight of almost about 1.5 kgs has been documented. Progression to dilated features with systolic dysfunction is seen in about 11 or 12% of men. Most of the men usually don't reach that stage of reproduction. But yes, women can have it, but that is because of several other things where you can have partial involvement, or there is something known as that the effective X-linked, which is supposed to be bad, is picked up, and the one which is good is rejected. In women, dilated 50 to 70% and hypertrophic cardiomyopathies both are noted at the time of presentation. Severity of cardiomyopathy is most important prognostic factor, and mean age for males at cardiac transplantation is 19 years. So they need cardiac transplantation rather early. So there are involvement in neurocognitive functions, visual, gastrointestinal, skeletal muscles, and cardiac psychiatric disorders. Cardiac is severe hypertrophy. ECG is hypertrophy with pre-excitation and impaired autophagy with vacuolization. These are differences between men and women. In women, you can have dilated cardiomyopathy-like features. In men, it is hypertrophic features. And these are some, this is a triad of cardiac, skeletal myopathy, and neurocognitive functions. In case you have this triad, start thinking in terms of Danon's. So these are the, for sake of revision or reiteration, these are certain things which we've already talked about. The problem is what to do. We don't have too much of solutions for it, except that there is one phase 1 study of AAV9, which is adeno-associated virus 9, LAMP2B gene therapy in Danon's disease. Hope, since it's only a phase 1 study, we don't know what are the outcomes going to be, but yes, it has some promise to us. Optimism continues, but we keep finding these children, which is very, very frustrating to treat and lose them before that. The biggest frustration in working up such patient is to await the results and await their death. It's so much so for my presentation. I'd be happy to take any questions just in case there are any.
Thank you, Dr. Samir, for the excellent case. So in all patients with marked hypertrophy of the left ventricle, the most common one which we see is the sarcomeric HCM. So in all the cases of HCM like hypertrophy, we have to exclude other genetic causes of left ventricular hypertrophy. For that, the best approach will be the red flag approach, which you have highlighted. So there, for each disease, there are red flags. We have to look into the other systems, ECG, other findings to suspect other types of genetic phenotypes and to diagnose and properly treat them. Any comments by Dr. Febrau?
Now, Philip can present his next presenter because we are getting late or so. So he can do his next
maybe
presentation.
well, thank you. It was a great case, and fortunately, it's rare, but it's also a frustrating case because indeed, in terms of therapy, we have not much we can do. I think you very well presented the differential diagnosis that needs to be done. You want to exclude the other type of cardiomyopathies. And well, hopefully, there is this phase 1 that has been published in 2025. Hopefully, and I know that they are now considering a phase 2. The result of the phase 1 were very promising. So we'll have to stay tuned on this very difficult cardiomyopathy that you just presented. So it is my pleasure and privilege to now introduce my colleague and friend, Dr. Ezekiel Guzzetti, who is a cardiologist at in Trois-Rivières in Quebec, and with a multimodality major and who did a PhD and fellowship with us in Quebec. So Ezekiel will present a case now, and he is in a clinic now, I think in a TE clinic. So we had to squeeze him. So it was supposed to be Dr. Julien Ternac presenting first, but we kind of switched to accommodate Ezekiel. So Ezekiel, you can share your screen if you can.
Yeah, I don't know if you do you see this my screen? I'm on the web version.
We don't see yet. So you have the share your screen.
Yeah, share, allowed to share screen. I'm sorry, screen, share this screen. Yeah, okay.
Is it
allowed to share window?
Can somebody guide him because you see
is it working? Because maybe I can get on the Zoom version. I'm sorry, it's not working.
Have you downloaded your slides? Yeah,
No.
now we can see. Yeah.
Okay, now I'm screen sharing. Maybe if because I'm on the web version. Are you seeing my screen right now?
Yeah.
Is the presentation on?
Yes.
Yeah, sorry, and thank you very much for the invitation. It's really my pleasure. As Philippe said, I'm in the middle of the echo clinic. It's been a crazy morning, but I'm really glad for being able to present with you. Thank you, Phil. As usual, you're one of the persons I can't say no in my life. So I'm definitely in. It's the bar is pretty high for the presentation, but I'm gonna try to make it short and sweet. So this is not as rare as the previous case, but I found it's really interesting. It's a recent case we had in our valve clinic. So it's are you all seeing the presentation?
Yes.
Good. So it's unmasked mitral prolapse post cardiac resynchronization therapy in non-ischemic cardiomyopathy. So I have no conflicts of interest for this presentation. It's going to be a pretty straightforward case presentation. The image is before the CRT, after the CRT, and a short discussion. So brief, it was a 70-year-old male who was hospitalized with a new onset heart failure, no previous history besides HIV, some previous history of consumption of alcohol and history of smoking, but stopped a couple of years later. Chronic kidney disease with which was mild, of stage 2, and absolutely no family or personal history of heart disease. This was his EKG at the arrival at the emergency room, which we can see sinus rhythm, left bundle branch block with a large QRS. This is the initial baseline echo. As we can see, there's a global hypokinesia, which is pretty severe. This is the 4D images, abnormal, asynchronism of contraction due to the left bundle branch block. And LVF was estimated at 15% with a severely dilated LV. There was some trabeculations, but no formal criteria for non-compaction, which is not anymore a cardiomyopathy, but a pattern. Strain was severely reduced as well, with a global GLS of minus 10.8%. There was a mild MR, which, as we can see here, it was non-significant, called either trivial or functional due to dysfunction. There was no other severe valvular heart disease beside a minimal aortic regurgitation was there. And so the findings of the TT were severe LV dilation with an end-diastolic volume of 115 milliliters per square meter and 5.7 centimeters of end-diastolic diameter. The LVF was severely depressed, estimated at 15%, with mild or trivial MR, likely functional. Cath was done, which was non-significant. There was an intermediate LA stenosis, but with no, which was non-significant at the functional test done at the cath lab. We did a CMR, which confirmed the findings. The LV was severely dilated. LVF was estimated at 17%, some degree of LVH, but nothing very severe, eccentric LVH. Normal RV volumes with a depressed RVEF. There was no edema. Some mild fibrosis, mostly septal and mid-wall infralateral of non-ischemic origin. And it confirmed there was no significant valvular heart disease. What we do at CMR, normally we do a Q flow at the aortic level or the pulmonary level. Or another way is we compare the Simpson between the volumes of the LV and the RV. And as we can see here, stroke volumes were depressed, which was compatible with the low stroke volume and lower cardiac output, but they were concordant, 49 milliliters on the LV and 48 on the RV. And there was also trivial TR, so there was no significant MR at the scene images or at the volumes. So our interpretation initially was a non-ischemic cardiomyopathy, depressed LVF, 17%, large QRS with LV bundle, left bundle branch block pattern. We treated it with the guideline-directed medical therapy, maximally tolerated doses, but LVF was not significantly improved. So he had a criteria for CRT-D, which was implanted with some minor complications, but everything went well afterwards. However, 3 months post-CRT, he presented at our heart failure clinic. The CRT-D parameters were optimal, but he complained of dyspnea, either almost functional class 2 to 3. He was a guy which was pretty active before this. So we asked for a TTE to see the LVF. This is the TTE post-CRT. We can see the defibrillator here, and function is pretty improved. Actually, with the auto EF was 53%, visually more 50%, but it was a significant improvement. Strain was somewhat improved, not impressive, but however, we started to see that there's a significant MR which was not present before, as we can see. And when we compare the TTE parameters before and after, the volumes were significantly reduced. The end diastolic diameter was from severely dilated or moderately dilated to normal. The end systolic volume was extremely normalized, extremely decreased. Stroke volume was improved. LVEF was frankly improved. The LA volume index was also decreased, but the MR severity from mild or trivial to probably moderate to severe at the TTE. We did a transesophageal echocardiography, and as we can see, there's some degree of prolapse with a significant MR. We can see here in the 3D, there's prolapse A2, P2, and A3, P3, with a significant MR. So the final report, we can see here the 3D, as was a severe organic MR due to prolapse, mostly A2, A3, A P2, P3. The 3D regurgitant at the orifice was compatible with severe. There was also, I didn't show the images, but reversal at the pulmonary veins. The anatomy was mostly favorable for a clip, and normal ventricular volumes and systolic function. So in conclusion, we had a new onset in IDEST, like unmasked organic MR, post-reverse remodeling with a severe symptomatic MR. And the patient is currently, this is a recent case, so I don't have the end of the story, but on the list for the microlip here in Quebec, unfortunately, waiting lists are pretty long. And so what I found interesting about this case, it's a little bit less rare than the previously presented, but normally in functional MR, we hope on the expected result is an improved of the MR severity, and that's what we saw in most sub-analysis, because a decrease of the tethering forces when there's a reverse remodeling of the LV, the tethering of the leaflets and the valve tenting all tend to improve, and so the MR goes from severe to mild or maybe almost normalized, like a trivial MR. And however, what we saw here, it was kind of paradoxical. I went to, because it was an interesting case, it's not my patient in the follow-up, but I saw her in the heart failure clinic. The mechanism, there are only very few case reports. The marked reverse remodeling can reduce the leaflet tethering and increase the closing forces. So actually, our interpretation is that there was a previous prolapse, an organic MR that was masked because of the severe LV dilation, which tends to tether and avoid the prolapse of the leaflets. And so the MR shifts from functional, which was trivial or mild in our case, to severe organic MR, which is come late after reverse remodeling when LVF normalizes. As I mentioned, there are two case reports in the literature. One in 2022 is a Japanese case, also a CRT, and the other is the one is presented here. Also, LVF improved from 15 to 49% and up to 58%, and there was an unmasking not only of the MR but also of mitral annular disjunction with a whole story of arrhythmia. But I think the probably the message, and I'd love to know your input, is the same. It's an unmasking of an organic lesion due to reverse remodeling. After, in this case, it was CRT, but it can also be GDMT, like a guide optimized medical therapy. And actually, this is rare but significant. Careful imaging follow-up is essential. I mean, we always do it anyway, and it might be in one of those clinical cases was surgical MVR, surgical mitral repair. But in our case, it's more candidate for clip, but this could be a physical therapy. So I'd like to thank you very much for your time.
Excellent, Ezekiel. I actually have to say I love this case because it's usually we do CRT to improve LV function, as you know, that was the main goal in your case, but also to improve MR. But this is when the mechanism of MR is secondary MR with excessive tethering, and so the CRT would reduce the tethering and therefore improve the coaptation and reduce the MR. And we have always seen this, and there are responders, non-responders, etc. But here, actually, what happened is most likely, as you said, there was pre-existing mitral valve prolapse that was a kind of corrected by the dilation of the left ventricle that occurred progressively. But then when you did CRT, it kind of reduced the tethering, which is good when you have, when you have type 3B MR. But in the case of a type 2 like this, actually it kind of resuscitated, if you will, the prolapse and then unmasked, as you very well said, the organic MR, and therefore said that you have maybe more than one problem. There was not only the problem of the left ventricle, and but also the MR. And maybe if we want to be a kind of strict, try to maybe order the sequences of events, maybe there was actually a primary organic MR that developed and then become severe, that eventually contribute to the dilation of the left ventricle and the dysfunction because it was probably missed, and then paradoxically the dilation and dysfunction of the left ventricle kind of reduced the MR, and now you're restoring
like a
it by
self-corrected MR. Like a
yeah,
self-corrected
exactly.
MR.
It's kind of a a compensatory mechanism indirectly. It rarely occurs, but plus the fact, I think there's the fact that because of dilation, you had less prolapse of the leaflets, and also because of the severe dysfunction, you had less also driving force, and gradient across the mitral valve. So when you kind of did the CRT, you reduce the tethering, you kind of restored the prolapse, if you will, and then also the driving force improved because now you have better contraction, better gradients across, and so the MR is now back to what it was maybe before. And yes, you will have to treat that for sure if you want to relieve symptoms. But that's very interesting. Any question or comments? Dr. Sengupta.
Yeah, when I read what I saw was like the EF was around 15 to 70%, but the GLS was minus 10.8. So there is something more to what is happening. You don't expect with 15% to be GLS to be around minus 10, 11. You expect it to be really down. So I don't know whether that can be a red flag to understand that why the GLS is so, relatively high. You expect it to be really down. Understanding the correlation that if the GLS is like almost 4 times, whether it holds true, I don't know. So that can be one of the things. But that's an interesting case, very interesting. Yeah.
Olagason can continue, please.
Yes, we'll go on.
Yes, we're going to move to the next case. Thank you so much, Ezekiel.
We'll go on to the
Thanks.
second presenter from IAE, Dr. Shantanu Sengupta. He is the consultant cardiologist at Sengupta Hospital and Research Center, Nagpur. He is the incoming president of the IAE and the scientific committee chairman for the ECHO India 2025. Dr. Shantanu, please.
Yeah, thank you, Dr. Allegation. So a simple case, but my slides are visible?
Yeah, visible.
Perfect.
So as Dr. Pibero had mentioned about aortic valve, aortic stenosis. So we know that LV dysfunction is a known fact in aortic stenosis, and it is there in the guidelines. But is LV dysfunction in mitral stenosis in the guidelines? Well, it has been under a lot of investigation. So this is a case of a young male who had rheumatic mitral stenosis, came with breathlessness, palpitation. There was no fever. The mitral valve area was a very severe MS. The planimetry was around 0.97. The peak by mean gradient was around 16/12 with an elevated PA pressure of 75. And as you can see, this patient had LV systolic dysfunction by biplane Simpson was around 40%. This patient had a pliable mitral valve for a BMV, underwent a balloon mitral valvuloplasty, and the mitral valve was opened up. Good mitral valve area. And as we expect, the peak by mean gradient reduced. The PA pressures were pretty good, and the LV function also improved. So post BMV, the LV function improved to almost 55%. Now you can see these are the views pre-BMV and post-BMV. There was an improvement. I mean, you can distinctly see an improvement post-BMV. Now the pressures went down. The patient started feeling better. Second case, a small case. Now this was another female. She was again had a severe mitral stenosis, came with breathlessness, palpitation. There was no fever. The gradients across the mitral valve was 18/12 with a mitral valve area of 0.9. The LV ejection fraction was preserved. It was around 55%. And we went on to do the patient was subjected to balloon mitral valvuloplasty, and post BMV, the mitral valve area was improved. She started feeling better. Again, the peak by mean was less post BMV. We got the strains. The LV ejection fraction was preserved, and we got the strains of this patient. These are the pre-BMV and post-BMV LV ejection fraction, which was preserved. Now, it was important to identify what was happening to the LV function. So the strain pre-BMV was around -13, and post-BMV the strains improved to -17. So LV dysfunction in mitral stenosis is known, and I can see Dr. Mohan joining. So they had reported way back in 90s that LV dysfunction is because of restriction or tethering of the myocardium by the scarred mitral apparatus. There can be because of the decreased loading condition. There can have right-sided, left-sided lesions. And if the patient had arrhythmia, atrial fibrillation, it contributes to the LV function. Then Partho looked at the effect of PTMC by looking at the tissue velocity, and they reported that the improvement can be because of the mobilization of the mitral valve apparatus, which causes reversal of this myocardial stiffness, which can improve the LV function. We looked at this work about looking at the echo investigation or looking at the LV function in mitral stenosis. So LV dysfunction in mitral stenosis is seen, should be evaluated both by biplane Simpson and by strain imaging, and it can be reversed acutely after relief of the mitral valve obstruction. And it should not stop us in looking at in giving this treatment of PTMC. So we did some work and we looked at the strain imaging in patients of mitral stenosis who underwent an PTMC, and we did report that LV deformation is reduced in patients with severe MS, and it is because of the hemodynamic changes, and BMV results in rapid improvement of the LV deformation. It is because mostly of the reduced LV diastolic filling rather than irreversible or structural abnormality which is present in the left ventricle. So this was a cohort of almost around 60 patients. Their mean ejection fraction pre-BMV was around 57. And if you can see, the GLS was around -9.9, which improved into 13.9. So I would like to emphasize that we are seeing patients still of rheumatic mitral stenosis, and if you are looking way beyond the LV function by strain imaging, we can identify this subset of population who, if treated well, can get a good quality of life. Understanding with what Dr. Pibero showed, that do we have to look more than the mitral valve apparatus, the RV function? I don't know, but I think what has been looked at, the aortic valve, should we incorporate it in mitral valve? I think should excite us to do some more work. Thank you so much.
Thank you, Dr. Shantanu. Any questions from the panel?
Any thoughts, Dr. Pibero or his team?
Yes, I mean, this is excellent, and to me, I think this is an important case. I think there is important takeaway is that never underestimate the presence and extent of LV dysfunction in patients with mitral stenosis. I think we should because generally when you have mitral stenosis, you're looking more at the left atrium and the valve per se, and is it eligible for balloon valvuloplasty or not? And we tend to kind of not look much at the left ventricle. You often do the LVF because it's standard, but generally not more. For example, I'm sure that in routine practice, very few do a global longitudinal strain on a patient with a mitral stenosis, right? So I think this should be systematic to kind of unmask, the presence of LV dysfunction. And I think in your case, and it's, to me, this has been always intriguing, what is the mechanism of LV dysfunction? Because sometimes it is pronounced, sometimes it is subtle, but sometimes it is pronounced. And I always thought that maybe the kind of the Frank-Starling law was the main mechanism, in the sense that there is insufficient loading, preload of the left ventricle, and therefore this directly impact contractility according to the Frank-Starling law. But maybe there are other factors, and you mentioned, the restriction eventually by the mitral annulus, because then the base of the left ventricle is kind of fixed, right, and cannot expand. And maybe when you do the valvuloplasty, this restore. So I think we probably should do more work. You should do more work on the deformation of the mitral valve apparatus pre and post, and how it correlates with the improvement in LV function. Arrhythmias also as well, but I think in the case of your patient, I think let's say the rhythm was about the same before and after, right? So it is not. Sometimes indeed you have AFib before, and then eventually it kind of improve after. But this is another factor, but maybe the only one. So yeah, a very interesting case.
I have a question for Shantanu.
Yeah.
Have you calculated the atrioventricular compliance in these people with normal left ventricular function and abnormal left ventricular function? The second one is in patients who have undergone balloon mitral valvuloplasty, if they develop a significant MR in a few cases, will the patients with decreased LV function, the depressed LV function, will not tolerate the mitral regurgitation that much as the other group which has a normal LV function?
Yeah, so I think I agree with you that AV coupling is an important thing, and I think the future ahead, I've not seen it personally in a series of patients, but yes, AV coupling, and also now the left atrial strain. Do they have some atrial myopathic process associated? Whether it affects, I don't know, but that can be interesting. Now, coming to MR, if they have severe MR, it changes the whole concept. I can see Dr. Mohan but he was a person who started this excitement about mitral stenosis way back in 30 years. But I do understand that AV coupling and left atrium can be another important thing, because I think now what excites me is the work on aortic valve, which Dr. Pibero showed. So are there other things which are contributing to the LV function has to be seen? Yeah.
We'll go on to the next presentation. Dr. Pibero.
Yes. So it is my pleasure to introduce now Dr. Julien Ternacle, who is from the University Hospital from Bordeaux. And Julien is an expert in imaging and management of structural heart disease, and has a strong interest with endocarditis as well. And so, Julien, the floor is yours. And what is this aortic valvular mass? That's the question, right?
Yeah, can you hear me?
Yeah.
Yes, very well. And we see your slide, but not in presentation mode for now. We're not in slideshow. Yeah,
No.
we are in presenter mode now. Yeah, that's good now. Perfect.
Okay. Thank you, Philippe. Thank you, dear colleague, for the invitation. So I will discuss with you this case of a patient with an aortic valvular mass. So my disclosure. The history of the disease of this patient is a 64 years old patient, male patient, which is an athletic patient with no previous medical history. He is fully asymptomatic on both cardiovascular and general levels. There is no fever, no chills, no embolic signs, nothing. And he has no treatment in his daily life. Because of his age of 60 years old and the athletic activities and sport activities, his GP has referred the patient for a cardiological assessment, a clinical consultation to continue the sport without risk. At this examination, the clinical examination was normal. The ECG was also normal, and the cardiologist performed a transthoracic echocardiography. So you can see here the transthoracic echocardiography on the parasternal long axis view. Oh, sorry, I have a small problem with PowerPoint.
Then come to your slides again.
Please share your slides again.
Yeah, I just open again.
I just had a crash, I think, of PowerPoint, so restarting is just gonna take a few seconds.
Good.
I will let it in this. So
Bring it to presentation mode, yeah.
you can see here you see it?
Yes.
Yeah, the long axis parasternal view, and we can observe an image of addition on the aortic valve. The next slide is on the apical view, the three-chamber apical view, so we can see a mass which is hyperechogenic on the mobile, on the aortic, on the ventricular part of the aortic valve. So the first question was for us to have a hypothesis, diagnostic hypothesis. So it could be an endocarditis or a sequel of endocarditis, myxoma, thrombus, metastasis, or fibroelastoma. So this is the 5 hypotheses which we had when we see the patient, and what is the diagnostic hypothesis which are the most probable. The endocarditis is possible because it's a vibratile mass on the valve, on the aortic, on the ventricular part of the aortic valve, but there is no clinical sign for endocarditis. And in our daily practice, we consider that a mass on a valve is an endocarditis until proven otherwise. Myxoma is not usually the presentation because it's not in the atria. Even if it could be other than in the atria, it's rarely on the valve. The thrombus is exceptional on a native valve, and there is no context for immunologic disease. Metastasis, same as for myxoma, is not usually on the valve, and there is no context of neoplasia, and usually it's in the myocardial part or in the pericardial part. And fibroelastoma is the second most probable diagnosis because of the localization and on the aortic valve and the mobility of the valve. So the test that we performed blood culture to isolate microorganism for the diagnostic of endocarditis. We performed serologies for the endocarditis with negative blood cultures. We perform both in the same time to avoid delay in the diagnosis because the patient has no fever and no symptoms or parameter in favor of the endocarditis. So we perform the serology to have the result the earliest possible. So Bartonella, Brucella, and Coxiella are the three main bacteria that can give endocarditis. So we perform the serologies. The cardiac CT to have an evaluation of the mass and on the valve. The cardiac CT was combined to whole body computed tomography to have, including the brain, to have an evaluation of the possible of the embolic complication, and also a TEE to better evaluate the characteristic of the mass. So I said blood culture because of the endocarditis possibility, the whole body. So I explain all the point. So here you can see the short axis view on the aortic valve using the TEE. We can see that there is a big image of deletion. Sorry?
No, go ahead.
Okay, there is a big mass on the non-coronary cusp of the aortic valve on the ventricular part. Using the biplane mode from the short axis view, we can well see the mass on the non-coronary cusp here on the LVOT view. So the mass is hyperechogenic. The measurement of the mass was 2 centimeters in the longer axis and 1 centimeter, 0.8 centimeter in the short axis. With the color Doppler on the biplane view, we can see that there is a regurgitation in regard of the mass, which is in the central part to the commissural part between the non-coronary cusp and the left coronary cusp. We can see here very well the extension of the regurgitation, which is at least mild to moderate. And on the CT, we can very well see the valve, which is thin, and the mass on the valve in the ventricular part of the valve, and there is no paravalvular injury in favor of the endocarditis. There is no abscess, no on the echo there was no perforation, no fistula. So to summary the test on the biology, there is a slight inflammatory syndrome with leukocyte at 12 giga per liter, and the CRP was a little bit higher than the normal value, but the patient has no fever. The blood culture were sterile, and the serologies were negative. So on the imaging exploration, we confirm that there is one large mass of 2 centimeters on the aortic valve. There is also a little, very small mass in addition on the aortic valve. The cardiac CT found the same analysis, and the whole body CT found no embolic complication. So the two possible diagnoses were a sequel of endocarditis for us, or multifibrillostoma, one main fibrillostoma and a second little fibrillostoma. The indication for surgery was based on the high risk of embolic complication because of the size of the mass. We did not start antibiotics prior to surgery because we don't think that it was an active endocarditis. The patient underwent a bioprosthetic surgical aortic valve replacement, and for the surgeon, during the operation, the aspect was highly suggestive of an infective endocarditis. So it's an important point. Here you can see the biplane view of the post-operative TEE with the aortic bioprosthetic in place with a good result. And I would highlight this recommendation. You know that we have a recommendation for the endocarditis, from the European Society of Cardiology, and there is also another society that work on the endocarditis, which is the XVID, the society more infectious society involved in the cardiovascular disease, infectious disease, and they used quite similar criteria from the ESC for the major criteria, microbiologic major criteria and imaging major criteria, but they add one other major criteria, which is the surgeon look during the operation. And for us, it's very important to discuss with the surgeon, because when the surgeon say that it's not only a chronic lesion, it could be an active lesion or an endocarditis, we should start early the antibiotics to avoid the contamination of the new device. So the analysis, the culture of the valve and the mass was negative, but the specific PCR analysis with the 16S RNA test was positive for Trophobina Whippleri, so the Whipple disease. And the final diagnosis was Whipple infective endocarditis of the valve. And it's a very rare complication. The Whipple disease is very rare, and the endocarditis complication was rare, is rare also. So it involves in young patients between 50 and 60 years old, mainly male patient without no risk factors. The presentation is usually very atypical, with a delay between the diagnosis, the final diagnosis of 21 months. The clinical triad of the disease is the arthralgia, digestive symptoms, and weight loss because of malabsorption. The CRP is often low, and there is frequently no sign of very important inflammation, but small sign of chronic inflammation like hypoalbuminemia and anemia, microcytic anemia. The manifestation of the infective endocarditis complication is mainly heart failure because of the destruction of the valve, and the aortic valve is most frequently involved. Systemic emboli are not so frequent, because usually in infective endocarditis in classical microorganism, with classical microorganism, we have like 40 to 50% of systemic embolic complication, and in the Whipple disease is very low. So the manifestation is usually very atypical. The diagnosis is mostly performed during the operation by the surgeon or after using the specific analysis. The treatment is surgery in 75% of patients because of the delay between the infection and the diagnosis and the destruction of the valve. We start with an intravenous antibiotic therapy and followed by prolonged oral therapy. And the prognosis is similar to the other endocarditis, with 30% of mortality at 1 year. So thank you for your attention.
Thank you so much, Julien. This is a great case, very rare and surprising result at the end. Whipple disease is rare, as you mentioned, and what I understand is that it's difficult to predict, obviously, because there is no obvious risk factors that you can identify. For example, the the people who do drug abuse, are not necessarily predisposed more to this endocarditis versus the others. So this is difficult to predict and to identify. The treatment also is different from what we do usually. I was wondering, so the indication here for the surgery, or the primary indication, was really the concern of embolization, right? I saw that the mass was also causing some, difficult to know, but some apparently maybe some significant AR. I don't know if you graded it or you did a quantitation. Was it moderate or more than that or less? It looked, visually it looked maybe significant, and it was maybe one of the other reason for indicating the surgery, maybe.
Yeah, the main reason was the risk of embolic complication, because when for the full history, the patient was seen in a hospital at 300 kilometers from our center. So my colleague who performed the TEE in the center sent me by WhatsApp the image, and he asked me, "What do you think? What can be this lesion?" And after discussion, there was no inflammatory syndrome or no clinical argument for the endocarditis. I asked him to perform the hemoculture, blood culture, to be sure that were negative. So I conclude to a fibrillostoma. And so the fibrillostoma, 2 centimeters of fibrillostoma is a high risk for embolic complication.
I see.
So we decide to perform the surgery mainly for the embolic risk.
Can you remove your slides, please? Can you remove the slides and then speak?
Please.
Unshare.
I can, yeah.
Yeah,
And,
now it is better.
Yeah. So yeah. Okay. Go ahead, Julien. We'll finish that and then move to the next speaker.
Okay,
That was an excellent case and nice images in the transesophageal echocardiogram. I also initially thought it was a fibrillostoma, but finally it turned out to be infective endocarditis. One of the, I think the pointing one is the high CRP, which was unlikely in a fibrillostoma. The CRP was very high. So we'll go on to the last case by Dr. Jesu Krupa, who is the Associate Professor of Cardiology and cardiologist working in Christian Medical College, Vellore. He is also the editor of our Journal of Indian Academy of Echocardiography. Dr. Krupa, please.
Thank you, sir. I hope my slides are visible and
Go ahead.
I hope I'm audible also. So since this is the last presentation, I'll keep it brief. I thank the Indian Academy of Echo, specifically Dr. Parasha, for inviting me. No specific disclosures except that I presented this in a recent Echo meeting, and some of you might have already seen this. But I chose to present this today specifically because of Dr. Philip and his team being here. And I understand there's a lot of work that he has done over the decades related to what I'm going to present. Hence, I thought it would be interesting to get his insights into this. So this is a 47-year-old male. He had an aortic valve replacement, which was done in 2002. Except for that, no other details were known. He has exertional dyspnea now and pedal edema for a month. Those are his details of height, weight, and body surface area of around 1.7 meters square. Blood pressure 110/86 and a heart rate of 88, which is regular. That's his ECG showing LVH and 1 VPC. There is cardiomegaly with pulmonary venous congestion, and that's his echo, the parasternal long axis view, which shows a severely dysfunctional left ventricle and the prosthetic aortic valve. again showing global hypokinesia. There is no focal area of thickening or thinning that we can see in these limited views. Again, what we can see here is that there is an increased color flow turbulence despite the low cardiac function. There is an increased flow turbulence that is seen across the aortic valve, prosthetic aortic valve, which is also seen in the short axis view. Disc mobility is noted. Some mobility is noted in the views that we have seen so far. This is again the four-chamber view, just to show that there is no significant mitral regurgitation, and of course there is severe biventricular dysfunction. What I have not shown here is that except for the aortic valve, which showed an increased color flow turbulence, all the other valves were unremarkable. Coming to the evaluation of the prosthetic valve itself, this is the LVOT VTI. And what we can see is that the VTI is very low. It's about 7 centimeters. And we also did a continuous wave Doppler as we would. And the valve flicks are seen quite well. The mean gradient is 14 millimeters of mercury. And what we have calculated here as a stroke volume is 47 ml, a DVI, very low DVI of 0.2. and a prosthetic aortic valve area of 1.2 centimeters square. So just to kind of refresh our memory on the evaluation of a prosthetic aortic valve as per the recent ASC guidelines, I'll quickly go through it. First and foremost, we give a look at the shape of the jet, and related to the shape of the jet are also the timings. That is the acceleration time and the acceleration time by ejection time. So you have a triangular or an early peaking or a short acceleration time, and that points towards a normal valve, versus a rounded jet with an increased acceleration time and an increased acceleration time over ejection time. And then, of course, based on the peak velocities, less than 3 and more than or equal to 4, mean gradient likewise less than 20 or more than or equal to 35. And again, good for our audience also to note that it is not mild, moderate, and severe, but it is normal, possible stenosis, and suggests significant stenosis. It's important to note that this is the terminology that we would use when we report also. And likewise, a DVI of greater than 0.35, which is normal, and less than 0.25. But the most important thing being that this is all at a normal stroke volume of 50 to 90 ml, or a normal transvalvular flow rate of 200 to 300 ml per second as per the guidelines. Now, if I were to just simply put the values as they are, as I showed you, obviously, you can see that they all fall in different categories. Starting with the contour itself, it looks somewhat intermediate. It's neither triangular nor completely rounded. Acceleration time is very short. AT by ET is more than 0.37. And the peak velocity is less than 3 meters per second. The mean gradient, of course, is less than 20. DVI falls in the significant stenosis range of less than 0.25, and the effective orifice area of 1.2, which is somewhere in the middle. But obviously, we cannot just look at these values, as we have everything is dependent on the flow. And in this particular case, the stroke volume index is markedly reduced, less than 35 ml per meter square, and the flow rate is also less than 200. This is just to not really to go through the different points as far as this algorithm is concerned, but how for our audience, just to kind of show in a snapshot how this differs from what we have currently. So when the jet velocity is greater than 3, initially we used to look at the DVI, and then we look at the jet contour, and then we kind of proceed. But as per the recent guidelines, they have kind of switched these things over, only to emphasize the importance of the contour, the shape, and the timings, which have been given more importance in the recent guidelines. The patient obviously had high filling pressures. E over E prime was 21.6, and you can see the markedly reduced tissue velocities and the filling pattern there. This, of course, goes without saying, markedly low global longitudinal strain of -4%. This is only to show that even in the right parasternal window, there is increased color flow turbulence, but the velocities and the gradients consequently are the same in both the apical as well as the right parasternal window. So the cause of the low gradient is not because all windows were not excluded. So the next thing is, of course, to do fluoroscopy in our with what is available. That is what we have. So this is what we most commonly do in the aortic position. And we can see that the range of motion is not completely normal. For this valve, assuming this is a Medtronic Hall valve, it would be somewhere around 65-70 degrees at least, but here it appears to be around 45 degrees or so. We went ahead and did a dobutamine stress echo. I'm not going to go through all the views, but this was at the maximum dose of 20 mics. And again, we see there is no improvement visually, there is no improvement in contractility or ejection fraction. This is a bit of over tracing here. But again, it gives us some idea. The VTI remains around the same, around 7-8 centimeters. The mean gradient also doesn't change. It was 11-12, again in the same range. The valve area also remains the same, around 1.2. Stroke volume also has not changed much. I have put the same in the form of a table starting with 0, 5, 10, 15, and 20 mics. And what we can see is that the stroke volume, first of all, the VTI doesn't change much. The stroke volume is in the 30s, continues to remain so. The aortic mean gradient is around 11, 12, 13. That is not much of a change. Ejection time also doesn't really change much. There are some oscillations, minor oscillations in that is just our recording and the measurements. The starting flow rate is 164, and it doesn't ever cross more than 200. Some variations can be attributed to measurements. But the story doesn't end there. What makes it more interesting is that we find that this patient has a dilated ascending aorta. And once we find that, the patient goes in for a CT, and the CT shows that the ascending aorta is dilated. It's 51 millimeters dilatation. What we also find is that in addition, the patient also has pannus. You can notice this black thing here. This is the prosthetic valve. I'll just come back, and that is like an arc which has been shown here. That is the pannus where the density or the Hounsfield units exceeds 200. These are just still images to show the entire arc of the pannus. So just to show where the pannus is located in relation to the hinge. So that is the valve, and that is where the hinge is. And this is the corresponding view, which shows the black thing there with the increased Hounsfield units, showing the pannus at the hinge. Again, we just tried to do a double orthogonal view to take the measurement of the orifice area. But obviously, this was done by a radiologist, and I don't think this is entirely correct because the stent struts and all that also has been captured in the orifice area. But conceptually, that is how we might do it, exclude the pannus and then try to measure the orifice. So in summary, we have a patient post-aortic valve replacement, which is not uncommon with metallic valves in our setup. There is possible stenosis due to pannus, which has been demonstrated with a restriction of the hinge mechanism. There is severe left ventricular dysfunction with no contractile reserve and also no apparent reason in terms of any focal problem in the left ventricle. There is an ascending aortic aneurysm, but it is not yet reaching 5.5 centimeters, which we would look for if it were a bicuspid aortic valve or a aortopathy, or even in a sporadic case. So I have 3 questions, and specifically for our guests and our experts, Dr. Philip, and also the other experts in the panel. So how would we manage this patient? Would we do an aortic valve and ascending aorta replacement? That would be a Bental. Would we do a cardiac MRI for LV tissue characterization? Would we just do medical management, or would we do a cardiac transplant? That is one. This was given by Dr. Philip many years ago, but this was a native valves. I assume it doesn't work for mechanical valves since there is no valve compliance. I just put it up there. Is there any similar way of assessing for prosthetic valves? And is the aortic valve area underestimated? I would think obviously because the flow rate simply doesn't increase. So is it predominantly just a flow rate related problem, or is the pannus, to what measure is the pannus contributing to the reduced opening? So these were some questions. I would leave it open for discussion and comments from our experts.
Thank you, Dr. Jesu. It's an interesting case. Dr. Philip, your opinion.
Yes, I mean, this is a very interesting and complex case, huh? Multifaceted, many problems. But yeah, I think, there is a dysfunction of the prosthetic valves. And I think you very well presented the algorithm. I think what you see from the echo, one thing that I'm using a lot, to kind of, it's not a confirmation, but at least a red flag that there is something wrong with the valve, is a Doppler velocity index. In your case, I did the calculation. You had a very low LVOT VTI, and the aortic valve VTI was not that impressive, but in proportion of the LVOT VTI, the ratio, so the Doppler velocity index was very abnormal, was 18. Usually when the DVI for prosthetic valve, when the DVI goes below 0.35, I kind of, it's suspicious. And when it's less than 0.25, it's more definitive that there is a dysfunction of the prosthetic valve. In your case, was 0.18, so clearly abnormal. So already there, that there is a high risk that the valve is dysfunctional. And then you can do the abutamin stress echo to confirm, because you have a low gradient situation, just as we do in native ES, as you nicely done. And yes, I mean, the projected valve area at normal flow rates is maybe less applicable for the prosthetic valve, but still, I think you can still look at the increase in gradient, to confirm the significance of the obstruction. And but the problem with the abutamin stress echo is you're very much dependent on the presence or absence of flow reserve. So if you have a patient who do not respond to the abutamin, you will not see any increase or significant increase in gradient, but it's non-diagnostic and the results are not conclusive. And that's why, for a native valve, we introduced this notion of projected valve area to be able to kind of project the valve area if the flow had increased to a normal flow range, to be able to get an idea of the valve area. Because we were confronted by, in native ES, I don't have the data for prosthetic valve, but in native ES, when you do a abutamin stress echo, in 50% of the case, you're non-diagnostic, non-conclusive, because of lack of flow reserve or insufficient flow reserve. And I guess it's even probably worse for prosthetic valve because the ventricle is more damaged, etc. So yeah, I think the abutamin stress echo is an option, but I don't use it much for prosthetic valve. I try to kind of make a conclusion on the resting echo. And if I have red flag at the resting echo, such as you had with the DVI especially, then I do some additional imaging, TEE or CTA, to better see the leaflet, the motion of the leaflets, the morphology, and if there is any pannus, thrombus, or in the case of mechanical valve, or leaflet thickening generation in the case of bioprosthetic valve. That's more my approach. I have the hemodynamic red flag on the resting echo, and then additional imaging to better see the leaflets and see if there is a dysfunction or if it's just prosthesis patient mismatch. Because let's say you have this case, you have some, let's say, high gradient across a mechanical valve. It doesn't mean that it is dysfunction. It could be prosthesis patient mismatch. But then if you do a TEE or cine fluoroscopy or CT angio, and you see the leaflets are moving perfectly, there is no pannus, no thrombus, you say, okay, the high gradient is due to mismatch. Okay. But if on the other end, there is abnormal leaflet motion, there is a pannus or thrombus that interacts with it, then you say, okay, this is a dysfunctional valve. And if it's thrombosis, you may try to use anticoagulation. Otherwise, it's going to be a redo surgery. And if you do a redo surgery, let's say that the patient is operable. Well, yes, I think, to answer to your other question, I would address the aorta at the same time, because, of course, the risk is higher with a bent than an isolated valve replacement. But given the ascending aorta, if you open the chest, I would do a bental, replace the valve and the aorta at the same time, not only the valve. I think that's what would the guidelines say. Again, if the patient is operable, etc., and the risk is. I don't know if
there are some questions in the chat box.
And the panel have some other comments.
There are some questions in the chat box, which Dr. Philippe Fabre has already answered. Whether you will do a TAVR in patients with low flow, low gradient AS paradoxical. Yes, definitely. If you confirm the severity by echo, and also if you want any support, you can get the support from CT scoring, etc. And these patients can undergo TAVR. The other one is the mild LVOT obstruction in the presence of severe aortic valvular stenosis. Again, TAVR can be done. If only thing is you should be very careful not to when to place the aortic valve at the position of the annulus or slightly above the annulus and not go into the left ventricular outflow tract. And there was a question about the use of LA strain. It's more useful for staging the disease and not for assessing whether the patient is suitable for TAVR or SAVR. So these are the questions which Dr. Philippe has already answered. If there are any other clarifications, questions to Dr. Philippe Fabre, we will be glad to answer, or to Jesse Krupa about this last case.
There's a last comment that in India, 2 centimeter LVOT diameter is very common. With this diameter, even at a DVI of 0.3, the estimated AVA will be 0.93 centimeters. How to resolve this discrepancy?
Dr. Philippe Fabre has described a method to, there is a formula for assessing the aortic valve diameter by, there is a formula. If you are measuring the LVOT diameter wrongly, then there will be a difference between the calculated diameter and the measured diameter. If it is more than 2 millimeters, you have to suspect that you have done the measurements wrongly. So that's the way we have to check the LVOT diameter and correctly do the calculation. Fabre?
Yes, I think, indeed, I think you can, the LVOT diameter is often the most difficult measurements that, and the issue is that it is squared in the continuity equation. So if you do 1 millimeter error on the alveolar diameter, it will translate into important error in stroke volume and therefore valve area. So really, you need to take the time, and most of the time, because we are a core lab for large studies, and so we receive echo from more than 100 hospitals, and most of the time, I see the measurements of the sites, and often it is underestimated. You can overestimate the LVOT diameter, but by TTE, The trend is more to underestimate. And one of the reasons is that, you know, previous guidelines, ASC, EACVI guidelines, especially ASC, were saying, oh, you should measure the LVOT diameter 5 to 10 millimeter below the annulus, because this is approximately where we put the pulse wave Doppler sample. So it makes sense to measure the velocity and diameter at the same time. The problem, if you do that, 5 to 10 millimeter, you're going to be on the septal bulge. You know, it's okay in patients with MR because, you know, the diameter at the annulus at 2 millimeter below at 5 or 10 will be approximately the same because the LVOT is cylindrical. But in patients with AS, often you have a septal bulge. And so if you measure 5 to 10, you're going to underestimate the LVOT diameter. So my recommendation, and maybe this is a very important takeaway, is to really measure the LVOT diameter at the annulus or very close, you know, within 2 millimeters of the annulus. So you want to stay on the membranous septum. You don't want to go down to the muscular septum. That's very important. And try to really select the best frame and the best window that really maximize the opening of the LVOT. So there is some, and I think if you do it right, the aortic valve area measured by echo is pretty reliable, but you need to do the effort of really measuring well the LVOT diameter. And also what I suggest is also systematically to look at the DVI, because when I have a valve area that is severe, less than 1, but a DVI that is non-severe, often suggests that I may have underestimated the LVOT diameter. Having said that, for sure, DVI is not perfect. In very small LVOT, which may often happen more frequently in India, yes, you may kind of, the DVI may underestimate the severity, and vice versa in very large annulus, this is the opposite. So I think the conclusion is that no parameter is perfect. And you should never rely on a single parameter. Never rely only on valve area, only on Doppler velocity index. Never rely only on gradient or peak velocity, unless they are very high, then it's no problem. But otherwise, I think you need to have an integrated approach, using all parameters that you're measuring, integrating them. If they are concordant together, you say, okay, I know now it's moderate AS, it's severe AS, or moderate prosthetic valve dysfunction. If there are some discordance, then you need to do more work, verify your measurements, and also very important, look at the leaflets. And this is valid for both native AS, prosthetic valve. Very important to look at the leaflets, you know, the visual estimation, semi-quantitation of aortic valve calcium score, eventually recommending a CT calcium scoring to have the anatomic severity of the stenosis as well. So it needs an integrated approach, multi-parameter, often also multi-imaging modality approach.
Thank you, Dr. Philip.
Thank you.
I think we'll thank all the participants, especially Dr. Philip Weberau and his team, and Dr. Samir Sivastava, Dr. Santanu Sengupta, and Jesu Krupa for presenting the nice cases. I think we'll meet again in future webinar. Thank you, all of you.
Thank you all.
Thank you very much to the Indian Academy of Echo for the invitation. I think that's been a great program. Thank you so much.
Thank you.
Thank you very much for the invitation.